The question was, there are many ways to treat high-risk prostate cancer from a radiotherapeutic perspective, be it LDR brachytherapy, HDR brachytherapy, SBRT, obviously all along with hormonal therapy. What is the optimal way of doing it? And that's not obviously established, but our best data is so far from the ASCEND-RT trial, where the combination of brachytherapy and external radiation, where most of the patients in that trial were high-risk patients. And so our approach is that that is the best form of dose intensification, and we generally use that. If the patients have gross extracapsular extension or seminal vesicle involvement, we prefer high-dose rate brachytherapy. If that's not the case based on MR imaging, then LDR brachytherapy is certainly appropriate, again, along with external beam radiation. SBRT boost along with it. We have some phase 1-2 studies looking at that, but I think we need obviously larger studies. Across the board anyway, we're talking about, based on trials, although it's never been tested in this dose intensification mode, talking probably about at least a year of hormonal therapy along with the treatment. So that's our basic radiotherapeutic approach.
Dr. Thompson?
I was at Astro as Anthony D'Amico asked some questions to the group of overwhelmingly positive hypofractionation presentations. And as I was listening to your eloquent presentation, Mike, about hypofractionation, I noticed a kind of a question, an observation, a question. Presumably, if hypofractionation works for intermediate risk disease, there should be no significant difference on its innate capability against higher risk disease. And since these are all underpowered for survival, do you anticipate that there will ever be any studies that will look at higher risk disease, hypofracs, and then be able to talk to us about its true impact on disease metastases and survival and so forth?
It's a great question, and it clearly depends, upon the way the trials were designed. One of those trials, the CHIP trial, these trials did include, some of these trials included high-risk patients. Some included low, intermediate, and high-risk patients. I think if we just look at the high risk alone, I agree with you, they're clearly underpowered in terms of survival. And I think we need future trials to look at the high-risk cohort, because I agree with you, there's no reason why, if it appears to be effective in intermediate risk, why we shouldn't explore this in the high-risk patient population. Clearly, a challenge is going to be, what do we do with the lymph nodes in these group of patients? Because in these trials, they generally were not treating the pelvic lymph nodes. There are differences in technique. And we do believe that in these group of patients, especially the high risk, we really need to address that. And I think we need changes in the design of the trials. Here at MSK, we've been exploring, and on a limited basis, for some younger patients who elect to get radiotherapy to undergo laparoscopic or robotic lymph node dissections to address at least the lymph nodes in conjunction with the radiotherapy. So there are many, many open questions, I agree.
Are there any high-risk trials in preparation in the co-op groups? Just specifically to look at that question?
You're talking about high risk in hypofractionation? Specifically for high risk, not to my knowledge.
Yeah. Neil?
A question for the panel, but perhaps Dan, as you spoke on this, we'll tackle it first. Certainly with the lower pricing now of germline post-mutational analyses, I'm wondering, we're starting to see a lot of patients come in with a BRCA, particularly BRCA2 mutation. I wonder what your thought is about surveillance in that patient. We've moved away from it, and we're sort of suggesting radical therapy, but I'm curious what you think or the panel think.
Yeah, sure. I mean, really the brains behind that at our shop is Heather Chang, who's really doing a remarkable amount of work with the germline, and Colin Pritchard, really originally from the metastatic work, but then we know that in the metastatic setting, probably somewhere in the 12 to 20% have BRCA2 or 1 or ATM or other DDR mutations. We know that in the screening population is probably much less, and we're looking at that in the canary population as well. the data would suggest that for those that have DDR, DNA damage repair in general, probably are not doing well. And if you look at the localized as a whole of who receive local therapy, they're still doing worse. And so by and large, we're also going away from, and maybe Phil Kantoff this afternoon might talk a little bit about it because in his talk, but we're going away from surveying people with BRCA2 in particular. There have been some groups, I know Taiwan as well as somewhere in Europe has done a prophylactic prostatectomies on a few people that have done BRCA2, but we're not doing that, of course. I don't know, Freddie.
Yeah.
Freddie.
No, I was going to ask another question. You and my surgical colleagues here and Mike as well. If you take rectal cancer, the patients receive chemoradiation and then surgery. Why are we not in that space? Can somebody give me some views here?
James
we
might
are,
be,
yeah.
yeah.
Well, not really. I don't think we have much conviction about it. I think some people are, but it's certainly not anywhere near becoming standard, and it's not being tested, as far as I know, in the context of RCTs.
I think there's a...
James might address that this afternoon a little bit more, but certainly I think from the standpoint of clinical trials. So I know I think Topelian has a clinical trial that was done using neoadjuvant hormone therapy and chemotherapy in patients, looking at certain biomarkers in patients afterwards. But there's now an interest in expanding that out to a lot more patients with high risk, and seeing, from the standpoint of not just feasibility, but from a biomarker aspect, what we're seeing in terms of managing high-risk patients in a multimodal way. And James's trial, in CLGB, helped to address that in a high-risk population.
So I have a question.
I think at least one consideration is that rectal cancer can't receive definitive dose levels of radiation up to 70 or 80 gray. We are very limited there to 50 gray. So our dose levels that we use for rectal cancer are basically adjuvant radiation dose levels. So we can't really extrapolate from the rectal experience to prostate. And the real question is only going to be answered in a randomized trial, if it would ever be done, of the triple therapy for one versus a triple therapy for the other.
But is there appetite to do that? That's the question.
I haven't heard anybody among the surgeons talk about the role of salvage lymphadenectomy, either after radiation or for patients who had prostatectomy with suboptimal node dissection. For a while, everybody who came in with a PSA that was rising was going for one of those. So I'd be interested in hearing consensus, if any, or thoughts about the role of this.
Neil, are you going to discuss that?
Oh, are you really?
Yeah, I think Neil's
Okay,
gonna discuss.
sorry.
Perfect.
Great.
Thank you.
Any other questions, comments, editorials? If not, thank you all, and lunch is served.